Hi everyone, welcome to today's quarantine clinic. Today we are discussing how to approach examination of gait. Right off the bat, gait examination is a very important aspect of neurological examination. So when in the overall scheme of examination, gait examination comes usually in the end. So when we do our neuro examination, we study gait after we check for higher mental function, we check for cranial nerves, we look for motor, sensory, coordination, and then we look for gait. But while this is the traditional way of examination, but it's important to remember that if you had to pick one test, if you had to just examine one thing, then gait examination should be that thing because gait covers almost every aspect of the neurological examination. So if you can see the person walking, that is, you will be able to tell a lot about whatever problem he or she is having. So the way we are going to discuss today's discussion is that we will first talk about the physiology of gait. So what happens in the brain and how does the brain control gait? How do we walk? And then we will talk about what all can go wrong, and then finally we'll talk about how can we analyze the patient. Let's talk about the physiology of gait, the neurophysiology of gait. Now, the when we talk of gait, we mean that a person is walking, so you immediately know that you need to move your legs. You also note that the person, when he's walking, you are maintaining your balance. You know that when a person is walking, that person has to see where they're walking. And you also need an idea of the environment because they need to know where they are going. So this is logical. So the one way to understand neurophysiology of gait is to think about all the inputs that are coming into your body and all the outputs that are leaving your body in order for gait to happen. So what all are the inputs that your body needs for gait? You need to sense if your legs are erect or are your legs folded. You need to sense what is the ground like under your feet. So basically your peripheral sensory system, primarily your proprioception. Now, to revise proprioception, this mainly involves your joint position sense. This goes up through your large fibers and it will go up via your dorsal column, and then it will enter the brainstem and then it will enter the cortex. So this is proprioception. Another information that we want is we want to know if are we facing upright or are we upside down? Are we on an angle? So basically, we need to know uh, if your body is horizontal or not, and that information is given to us by the vestibular system. So we have not discussed the vestibular system in detail yet. Maybe we can take that. We can take another discussion just on the vestibular system because it deserves an entire discussion. But for now, just know that the function of the vestibular system is to maintain balance. So the vestibular system is what decides if your head and your body are in a straight, are both parallel to each other, or is your head turned to one side, or is your entire body turned to one side. So when you are in a roller coaster and you go upside down, it is your vestibular system that is telling you that your body is upside down. The other sensory inputs come from your visual pathway. So you need to be able to see where you're going, and you need to be able to see if there are any obstacles in front of you. And there is an auditory pathway. So you need to hear the things around you. So auditory and visual will give us information about the world around us, and vestibular and proprioception will give us information about your own body. So all of these things put together will enter the brain, and then your brain can make the decision of whether or not to walk and where to walk. And another piece of information that your body needs is carried by your spinocerebellar tract. So the function of the spinocerebellar tract is that your cerebellum, we have already discussed cerebellum, then the main function of the cerebellum is to make your corrections. So make sure that everything is functioning smoothly. And so your cerebellum needs a continuous input of information, whether the command that has been given, is it working fine or does it need some adjustment? So your spinocerebellar tract will give that information. So all of these put together form the sensory input for gait. Now what happens? So in the brain, all of these sensations have now gone up, and they'll go all the way to the frontal lobe. Now you will decide that you need to start walking. So your frontal lobe makes that decision, and your frontal lobe will tell certain centers in your brain stem, and your centers in your brain stem will then tell centers in your spinal cord, and those centers in your spinal cord will ultimately cause walking. So what are these centers called? They are called as pattern generators. And if you understand this term, then it makes it a lot easier, because walking is not like your other actions. So if your brain decides to lift your right hand, then it is a simple decision of moving 2-3 muscles in your arm in a sequence, and then that is it. So you lift your right arm and that's over. But when it comes to walking, think of the amount of information that needs to flow. Your brain needs to continuously tell the muscles of one leg to contract and relax, and at the same time your other leg has to do the opposite action, and that has to continuously keep happening, and at a very fixed frequency. So if it doesn't happen at a fixed frequency, you will be walking in a jerky manner. It's not in a smooth way. And supposing you don't follow that sequence, then your both legs may be contracting together or relaxing together. So then you won't be able to walk. That is why there needs to be a pattern. And the pattern generators in your brain are in the brain stem. And this is called as locomotor center. I'll explain how the locomotor center leads to walking, but for now, just remember that there's a locomotor center in the brainstem, primarily in the pons and the medulla. And there is another center in the spinal cord. So this is at a very local level, and the center in the spinal cord also does the same action of exciting and inhibiting the opposite muscles. So if your extensors are contracting, then your flexors need to relax, and so on. Okay, so now how does this happen? How does the brainstem control the spinal cord, and then how does the spinal cord control the muscles? So for this, I want to revise the concept of flexors and extensors. So when you are walking, your anti-gravity muscles in your legs are primarily acting. Your hip has to extend, your thighs have to, your knees have to extend, and your ankles have to extend. So they are all extensors of your lower limbs. And when one one leg is extending, the other one has to flex. So there has to be continuous alternating flexion and extension of your lower limb muscles of each leg. Now, you know that your main tract that controls the muscles of your body is known as corticospinal tract. So this corticospinal tract arises from the motor cortex and then comes down to the brainstem, crosses over, and then comes down to the motor neuron and then controls the muscles. So we have already discussed this before. But think of how difficult it will be if you have to control all the muscles of your lower legs for walking via your corticospinal tract, because that would mean that you are consciously trying to flex your hip, extend your hip, flex your knee, extend your knee, flex your ankle, extend your ankle continuously all the time. It is not going to be feasible, and somewhere there will be a gap in that pattern. So because of that, you have pattern generators, and the two tracts that support the corticospinal tract and modulate the corticospinal tract are known as vestibulospinal and reticulospinal. So what are the functions? What does the vestibulospinal tract do and what does the reticulospinal tract do? So vestibulo means it is arising from the vestibular nucleus. And the main function of the vestibular nucleus, like I said, is to maintain balance. So vestibulospinal tract is primarily involved in maintaining posture. So vestibulospinal tract is more important for standing than walking. So there is a huge element of balance while walking also, but it is easier to understand vestibulospinal when we just think about it in terms of posture. So when you are just standing, it is your vestibulospinal tract that continuously carries information up and down regarding how much should your axial muscles contract, how much should your leg muscles contract in order to just maintain your posture. So that is the function of the vestibulospinal, and it mainly does this by two tracts. So vestibulospinal has one lateral tract and a medial tract. I won't go too deep into this, but both of them acting together will modulate your axial and your lower limb tone to make sure that you are standing erect. Now, in locomotion, that is in gait, the main tract that we want to talk about is reticulospinal, because this is primarily for locomotion. Now, where does this come from? So the word reticulo means it is coming from the reticular formation. The main concept of reticular formation is that it is spread out over the brainstem. And the primary role of the reticular formation is consciousness. So now you may have attended the consciousness talk on Sunday, but if not, then remember that there is a reticular activating system, and that is primarily involved in awakening and your conscious state. Now, that same reticular formation is also involved in movement. And the tract that arises from the reticular system is known as reticulospinal tract. And the reticulospinal tract receives information from the cortex. So when we speak of the reticulospinal tract, we actually mean cortico-reticulospinal tract. And this is what will control your spinal cord pattern generators via your lateral and medial reticulospinal tracts. And the way it does this is by alternately stimulating the extensors and stimulating the flexors. So I'll just going to talk about this for one more minute. The lateral reticulospinal tract arises from the medulla, and the medial one arises from the pons. And it is a function of the medial one. So the one that arises from the pons, it is the role of the medial one to stimulate the extensors and inhibit flexors of that side. And it is the role of the lateral one, that is the one that comes from the medulla, to excite the flexors and inhibit the extensors and also inhibit the medial one. So by modulating your medial reticulospinal and lateral reticulospinal, you are able to alternately stimulate the extensors of one side, inhibit the flexors of that side, stimulate the extensors of the other side, and so on. So in a cycle, this whole system is carried out by the reticulospinal. And in the backdrop of the reticulospinal, your vestibulospinal keeps your balance. So while you're walking, the continuous forward and backward movement is done by your cortico-reticulospinal tract, and your balance is maintained by your vestibulospinal. So these are the two aspects of gait. All right, now let us come down to what is gait itself. So what is gait and what are the aspects of gait? Gait is walking. So when you are walking, your right leg lifts off the ground, you raise it in the air, move forward, and then your right leg strikes the ground again, and then you move forward, and then again it lifts off. And at the same time, your left leg does the opposite action. So these two parts of gait are known as the stance phase and swing phase. So the stance phase is the part of the gait in which your leg is in contact with the ground. And swing phase is the part of the gait when your leg is in the air. So each leg will have a stance phase and a swing phase, and usually they're alternating. And there is a 10% of the time in the middle when both your feet are on the ground. So then both of them are in the stance phase. So let's just take the right leg and let us look at the stance phase. So what happens in the stance phase? So there are 4 parts to the stance phase. So when you're walking, initially your heel will hit the ground. So the first part of the stance phase is heel strike. It is also known as initial contact. So that is how you walk, when your heel hits the ground, and then gradually the weight will get shifted anteriorly on your foot, and it will go from your heel to the ball of your foot, and then the heel will lift off the ground, and then finally only your toes are touching the ground, and then finally your toes have lifted off the ground. So these 4 parts of stance phase are known as heel strike, loading, mid stance, and toe off, also known as push off. So this is the terminal phase. Okay, so these are the 4 parts of the stance phase. So when your foot is in contact with the ground, after that, that foot is now going to be swinging and it is going to move ahead. So this is called as a swing phase, and this also has 4 parts to it. One is called as the pre-swing, in which your leg is behind your body, and then the initial, when the swinging starts, the mid, and the terminal swing. And this is again followed by heel strike. So then you're back to the stance phase. And usually it's 60% of your gait is in your stance phase, and 40% is in the swing. And part of that 40, 60%, 10%, both your feet are on the ground. All right. So this is gait. This is the aspect of gait. There are some other aspects to gait which doesn't have anything to do with the lower legs, and one of them is called as arm swing. And other things that you need to look for is other abnormal movements. Okay. So, okay, we'll discuss this later. What all will you look for when you see someone walking? So what all are the aspects of gait that you want to pay attention to? So one is when the person is standing. So in the stance, you will see whether how wide is the base. So when someone is standing, the distance between the feet will tell you a lot of things, because the wider the distance, that means that more the problem with a balance. Because if someone has no problem with the balance, then you can keep both your feet quite close together and still maintain balance. But then if you have any problem with balance, then your feet will get wider and wider apart. So this is known as wide base stance. And this is one of the first things that can go wrong in any balance related issue. So that is, if there is a sensory problem, if there is a cerebellar problem, if there is a vestibular problem, anything that affects your balance, your stance will get wider. Now, this wide base can also be seen in walking. So not just while standing, but even when walking, you can see that the distance between your feet when they swing across each other, usually between the two malleoli, between the two medial malleoli, there is a distance of around 2 inches. But when you're walking, if the distance is more than 2 inches, then that means that it is a wide based gait. What else will you look for? When the foot is about to lift off from the ground, so that is in the toe off phase, you want to check if if the patient's toe is completely off the ground, or is it still dragging. So if there is poor toe clearance, that can be a sign of foot drop. What else do you want to know? You want to see the stride time. So how much time does it take for that person to complete one stride, the step length, step time, overall velocity, so how much distance in how much time, and something called as cadence. So cadence means number of steps per minute. Now, why are these things important? Because if you have a patient with some problem in gait, you don't know what the problem is, and it's supposing it is too complicated, you are not able to analyze, the way to approach it is to at least document what all problems there are. Even if you are not able to conclude why this is happening, document whether what is the distance between the base, document whether toe is getting lifted off, document what is the stride time, the step length, velocity, and cadence. What this does is that it gives you a baseline for comparison. So later on, you can see whether the gait is worsening, or is it static, or is it improving. So that is why these parameters are important. And you should also have some sort of idea as to what is normal. So in a normal adult person, you can walk around 80 meters in 1 minute, and the cadence is approximately 110 to 115 steps per minute. Okay. And the stride length is approximately 1.4 meters. So when you take one stride, you are covering around 1.4 meters. So these are things to look for when you examine somebody's gait. Now I want to talk to you about how do you correlate what you see with clinical problems. So when you see somebody and you know that they are not walking normally, the first thing to do is to document exactly what is abnormal, and then you try to correlate it with why should this be happening? Why should this abnormal gait be happening? I wanted to tell you one more thing. When you are looking at arm swing, you also want to look at hip movement. Okay, so abnormal arm swing, abnormal movements, and abnormal hip movements. And now we look at clinical scenario. So what all are your requirements for a normal gait? You need your peripheral sensations to be intact. So peripheral sensations meaning your nerves, your large fiber nerves mainly, because that is what carries your sensation. You also need your muscles to be intact, because if your muscles are not working, then there will be weakness. You need your neuromuscular junction to be intact, because that is what will give the signal between your nerves and your muscle. You need the entire tract of your nerve all the way to the spinal cord. So that means your plexus and your roots, all of them should be intact. In the spinal cord, you want your tracts to be intact. So the spinal cord will carry the information up through the dorsal column. So that should be intact. Your brainstem, where the crossover happens, that should be intact. Your cortex should be intact, because that is where the thinking happens. Your cerebellum should be intact. And then the fibers that will come down. So both your corticospinal tract and the reticulospinal tract and the vestibulospinal tract, all of them should be intact. And then finally, the output. So this is the entire system of neuroanatomy that you need for a normal gait. And of course, I also forgot your vestibular system, also in your brainstem. So all of these should be intact for a normal gait. Now, if any one of this has a problem, if there is a sensory nerve problem, if there is a neuromuscular junction problem, if there is a muscle problem, if there's a motor nerve problem or a root problem or a spinal cord or a cortex or a vestibule or a cerebellar, any one of these, there will be a different gait. And that is why gait examination is so important, because if you know gait examination properly, you can pretty much differentiate between all these different etiologies. So when we discussed our all our cases, we always started with where is the lesion, and you can already see that if you can evaluate gait, you have a pretty good idea already of where is the lesion. So a lot of times when I see a patient, the first thing I do is, after taking history, in examination, the first thing I do is ask them to walk. So if they're able to walk, then that in itself gives you a lot of clues that their uh, mental functions are relatively intact. They are still able to understand what I'm saying. And the way in which they walk will give us a lot further clues. So now let us see what all can be the different presentations in gait if there is a problem in all these areas. The etiology of gait disorders has been sort of classified into three parts. It is known as lower level, mid level, and high level. So the differentiation is mainly done in the site of the lesion. So a lower level lesion is something that is in the periphery. A mid-level lesion is something that is below the cortex, and a high-level lesion is something that involves the cortex. So your nerve problem, muscle problem, neuromuscular junction, root, plexus, all of that will become a low-level problem. A mid-level will be a spinal cord, the cerebellum, or a basal ganglia, and a high level will be your frontal lobe dysfunction. So that is a rough differentiation of the etiologies. Now let us look at what can be the presentation. and I want to go from periphery to center. So I want to start off with the peripheral nerve and then go on to the center. Now let's look at peripheral neuropathy. You know that your peripheral nerves have two parts, your sensory nerves and your motor nerves. If there is something wrong in your sensory nerves, you are unable to sense mainly your proprioception, your joint position sense, and that leads to something called as sensory ataxia. Practically speaking, what that happens is the person is standing, and ideally the joints are supposed to give information up saying that are they completely extended or flexed. But if the nerve fibers are gone, then your brain doesn't know if are both your legs completely extended, or is one of them flexed, or is one of them slightly abducted or adducted. And so there is imbalance because your brain is continuously trying to adjust to something without having full information. So this is known as sensory ataxia. And the way the brain overcomes this is through visual cues. So what it does is that if a person is if a person is standing here and he doesn't know if his legs are erect or not and whether he's sitting or standing, then what he does is that he will pick a point in the opposite wall. So supposing there is a clock on the opposite wall, he will see that point, and his vision is working fine and his brain is working fine. So now he is able to calculate that the wall is so much distant from me, and this distance is not changing, so it is not going up or down. So that means that my body must be still. So it uses visual cues from the environment to calculate if whether the body is stable or is it unsteady. But as soon as you remove the visual cue, now the person is completely dependent on the sensory cue, on the peripheral nervous system, and then again there is imbalance. And this test is known as Romberg's test. So Romberg's test is basically when you ask the patient to stand and with his eyes open, there is not much imbalance. But as soon as the eyes are closed, there is significant imbalance. There is risk of falling. That is Romberg's test. If there is imbalance even when the eyes are open, that is not Romberg's test. So that you won't say Romberg positive if there is uh, ataxia or there is imbalance when eyes are open. So Romberg classically described it in a patient with sensory ataxia. Specifically, he described it in tabes dorsalis. So in tabes dorsalis, your dorsal column of the spine is involved. So all your sensory input to the brain goes through your dorsal column, your proprioception. So when that goes, your brain doesn't have any sensory input. So he described it in tabes dorsalis. Uh, there are certain aspects to Romberg's test that we now do. Like for example, we tell the patient to put both the feet very close together. We tell the patient to hold arms up or arms on one side. Now, these are all later additions. Romberg did not describe all of that. Romberg just described standing and eye closure, but we added the others for different reasons. So if you put both your feet together, it makes it more difficult. So it makes the test more sensitive. And holding the arms in front is a way of combining pronator drift and Romberg. So you can do both those tests together. So if your patient is standing and arms are outstretched in front and eyes are closed, if there is imbalance, then you know that. And if not, then you can check for pronator drift. That is why you hold your arms in front. And so peripheral neuropathy, in your sensory peripheral neuropathy, this is what happens. You have sensory ataxia. And clinically speaking, so when the patient comes to you, what happens is that the patient with eyes open, he still doesn't have an idea that whether his legs are how what is the position of his legs. So when he is walking and his one leg has lifted off the ground, he doesn't know what distance there is between the leg and the ground. Because in a normal person, when you lift the leg, you have an idea of the angles to which your leg has flexed or extended. So you know how far the ground is. But in this person, he doesn't know. Is the leg extended only till here, or is the leg flexed all the way till here? So he doesn't know whether your leg has to come down till this much distance, or is it only this much distance. So that is why when your leg comes back to the ground, oftentimes it will hit hard and there is a slapping sound. Okay. And also, if he's trying to walk and there is some obstacles in the way, which usually there will be some rocks, some stones. He doesn't know whether he is able to just lift the leg above, and he doesn't want to take any risk. That is why he will lift his leg all the way up to make sure that he is clearing all the obstacles. So this is known as high steppage gait. So of course, when he is looking down, he's able to see the obstacles, but when he lifts his leg, he's not able to be 100% sure that he has lifted it high enough. So he will lift it too high. And when he brings it back down, because he's not sure of the distance, it will come back with a thud. So there's a slapping sound. So these are the characteristics of gait in sensory ataxia along with Romberg's test. What if your motor nerve is involved? So if your motor nerve is involved, usually there is a distal involvement. So we already discussed in neuropathy how your distal nerve gets involved before your proximal. So if your distal motor nerve is involved in your leg, the way it usually presents is there is weakness of dorsiflexion. So dorsiflexion is when your toes are lifted up, and plantar flexion is when your toes are pushed down. So if there is weakness of dorsiflexion, what happens is your feet will now drop down, and that is known as foot drop. So there is a lot of reasons for foot drop. It can be anything from a very local nerve problem, a common peroneal nerve problem, a sciatic nerve, or a root. So anything can cause a foot drop, but in this case, they're talking about a peripheral neuropathy. And suppose there is a traumatic injury to your peroneal nerve, or if there is, say, lead poisoning, so then you can have a motor neuropathy and you can have foot drop. Now, clinically, how would a foot drop present? There is nothing wrong with the sensation this time. So the person knows that the obstacles are there. The person knows how high the leg is lifted. But when you lift the leg, the side of the leg with the foot drop, normally the foot should be raised up. So when you are walking, when you are in your swing phase, you will notice that your toes are pointed upwards. They are not pointed downwards. But in this patient, because there is foot drop, the toes are pointed down. So even when there is a swing, there is a chance that the toes will graze the ground. So this is known as toe graze. And what this can lead to is that sometimes the patient may trip. So if there is a low obstacle, the person will feel that I have lifted it high enough, but he won't calculate the toes being still dropped. And so that toe may hit the obstacle and then the person may trip. So these are the two characteristics of motor neuropathy with a foot drop. You can have toe graze and you can have tripping. All right, now let's move a little higher up. Let's talk about if there is a muscular weakness. Now, you may wonder why I said muscular on top of neuropathy, because anatomically, the nerve will end in the muscle, but clinically, a neuropathy will present distally, and a muscle weakness, so that is a myopathy, will present with proximal muscle weakness. Okay, so your proximal muscles are involved more in a muscular weakness. So in a muscular dystrophy, for example, or any myopathy, it will be your quadriceps, the gluteal muscles that are involved more. So now, if you're going anatomically, then the muscular weakness will be higher up from the neuropathy. So in a muscular weakness, what are the characteristics? Usually it will be bilateral. Usually a muscular weakness is bilateral, and there are a couple of things that can happen depending on which muscles are involved more. So different myopathies will involve different sets of muscles, but in general, the muscles involved will be your hip flexors. So hip flexors will move your hip forwards. The hip flexors are your iliopsoas muscles. So they are also responsible for uh, flexing your thigh. And so if there is a hip flexor weakness, then your hip extensors will act more. So if you're looking at somebody from the side, then if there is no hip flexion, then there will be hip extension. So your hip will move backwards, and this is known as lumbar lordosis. So that lumbar lordosis is due to hip flexor weakness. The other hip muscle that can get classically involved is hip abductor. So hip abductors are the muscles that will take your legs away from the midline, and your the main hip abductors are your gluteus medius muscle. And here there is one sign I want to tell you about. So if there is a gluteus medius muscle problem, so there is a gluteus medius weakness, what will happen? So let's first take a unilateral gluteus muscle weakness. So supposing that only one side of the muscle is gone, then the other side muscle is acting. Okay, so in this person, if this is the right side and this is the left side gluteus muscle is acting and the right side is gone. Now, I want you to think of the pelvic bone. So let's say that this is the pelvic bone. How the gluteus medius muscles act is that they are attached from the pelvic bone downwards, and they pull the legs outwards. But at the same time, if the leg is on the ground, then they will pull the pelvic bone closer to the leg. So if your leg is on the ground, then the same muscle will pull the pelvic bone towards the leg. Now, imagine that you are standing, and your pelvic bone is absolutely horizontal to the ground, and you are stable. You are not walking. Now imagine that you have lifted up your one leg. So you've lifted up just your right leg. Now think that your pelvic bone may now tilt downwards on that leg because that support is gone. So till now your pelvic bone was balanced on top of both your legs and both of them were on the ground. But if you remove the weight from one leg, that pelvic bone, that side should drop down. The reason it doesn't is because as soon as you lift one leg, your opposite side gluteus medius will contract and it will pull the pelvic bone back to your horizontal level. Okay. Now, supposing your opposite side gluteus medius is weak, then this correction of your pelvic bone will not happen. So as soon as you lift one leg, your pelvic bone will drop on that side if there is a weakness of your abductor muscle on the opposite side. Okay, and this is known as the Trendelenburg sign. If your one leg is lifted up, then your pelvic bone has a risk of dropping on that side. It normally doesn't because the opposite side gluteus medius contracts. But if there is a problem with this gluteus medius, if this gluteus medius is not acting, then the pelvic bone may drop on that side. And this is known as Trendelenburg sign. Now, what does this do? So now if this person is lifted one leg and he's standing on one leg and the pelvic bone has dropped, the problem is that the center of gravity, which is usually in the center, it is around S2, this center of gravity will shift because now this has dropped here. So now the center of gravity will shift towards the side where your leg is raised. So in order to compensate for that, the person will move his body to the opposite side. So he will sway his body towards the side of the weakness just to make the pelvis horizontal again. And that is how he will walk every time his leg is raised up in order to avoid the pelvic tilt. It is also known as pelvic ptosis. In order to avoid that pelvic tilt or pelvic drop, he will sway his body to the opposite side and walk. And if there is weakness on both sides, if there is abductor weakness on both sides, then there will be bilateral swaying as you walk, and that is known as waddling gait. Now, there are only a couple of more things that I want to cover. One is spastic gait. And spastic gait can happen either because of your cortical problem. So you can have a stroke. So that will be a hemiparesis. So one side spasticity, or it can be a diplegia. So your both lower legs will have spasticity, and this can be seen in a myelopathy or a cerebral palsy. So there are a lot of reasons, but spastic paraparesis or a hemiparesis. Now the difference is that in hemiparesis, you will have hemiparetic gait, which is classically circumduction. So what happens if you have a stroke, your one side, so supposing you have right-sided hemiparesis, your right leg will be extended. You will have trouble flexing it because your corticospinal tract is gone and extrapyramidal tracts take over. Your anti-gravity muscles will act more. So your anti-gravity muscles in your legs are your extensors. So your legs will be extended, including your ankle. So your ankle will be plantar flexed. So the effect of that is that now your right leg is a little longer than the left leg, because your left leg, your ankle is not plantar extended, but your right leg is. So now when you're trying to walk, you can't walk normally because your right leg is longer than the left. So then, and also you're not able to flex your right leg. So what happens is you take your right leg, move it in a circle around so that you're able to clear the ground. So that is known as circumducting gait. And supposing you have spastic paraparesis, so both your legs are now like sticks. So both of your legs you are unable to flex. Then you can't. What happens is that there will be scissoring. So instead of going outside, they will go inside when they walk. Okay, so that is known as a scissoring gait, and there will be scraping of feet. So the scraping of feet is because of that. There is plantar flexion of your ankle, and so every time you walk, the toes will scrape against the ground. Okay, so hemiparesis, circumduction gait, and paraparesis, spastic paraparesis, scissoring, and scraping of feet. So that covers your spastic gait. Now I want to talk about your cerebellar gait. So the way that they describe cerebellar gait is a drunk person gait. Now think about what the cerebellum does. The cerebellum is involved in correcting errors, one, and it is involved in connecting your individual movements to each other to make it into a smooth flow. So supposing there is a cerebellar problem, you will have dyssynergia. So you need to extend your knee and flex your thigh and then extend your ankle, but you may not be able to do it in a smooth way. So you may do one thing, stop, then do another thing, stop, then do a third thing. And this happens on both sides. So you can have a variable gait. It may not be exactly similar every time the patient walks because the sequence in which they are moving their legs may be variable. It is erratic. It is shuffling. There will be swaying. So there will be imbalance towards the side of the lesion. They may have difficulty in maintaining balance. They will tend to fall towards the side of the lesion. And there will be other cerebellar signs. So if you remember from our cerebellar discussion, you can have intention tremor. So even when they're walking, there may be tremor of the legs when they're trying to place their leg at a particular spot. There may be oscillation. So you can have titubation of the head. So there may be oscillation of the body. There may be tremors. There is erratic walking, variable walking, shuffling, and swaying towards one side. And all of this can be seen in acute alcohol poisoning. So for good reason, because alcohol also affects the cerebellum, mainly the vermis. So in a cerebellar dysfunction, if there is a central cerebellar problem, there will be a central gait problem. So you will have danger of falling backward and forward. And if there's a lateral cerebellar problem, you will have more problem with moving your legs. So that we discussed in our cerebellar discussion. But imagine a drunk person gait, and that is sort of what a cerebellar gait will look like. One important thing I want to say is that they will have swaying even on eyes open, because in a cerebellar dysfunction, the brain is getting all the information. The brain is giving also all the proper commands, but the problem is in the integration. So it doesn't matter if your eyes are open or shut. If they are shut, they become worse. But even if your eyes are open, if you're not able to integrate your information, it doesn't matter what information you have. So that is why even with eyes open, your Romberg, if you test for your Romberg, even with eyes open, there will be swaying. So that is why they say in cerebellar dysfunction, your Romberg is, you can't say Romberg positive because they are swaying even with eyes open. And finally, last two things. One is known as the Parkinsonian gait. The Parkinsonian gait is classically known as the akinetic rigid syndrome. And the main aspects of this is bradykinesia, rigidity, and tremor. So in a Parkinsonian gait, the characteristic features are, it is shuffling, there is stooping, it is slow, stiff, with small steps. Okay, so multiple S factors. So Parkinsonian gait, the person will be walking very slowly. The steps will be small steps, shuffling steps. The entire body will seem stiff and the body will be a little stooped, stooped in front. Other features of Parkinsonism will be there. So mask-like face, blank stare, there will be no blinking. The hands will not be swinging. There may be a tremor in the hands known as the pill rolling tremor. And if you ask the patient to turn around, they will not be able to turn around quickly. They will be turning slowly. So they will be taking multiple steps to turn around, and they'll be turning around the whole body. They can't turn just the upper part because of stiffness. So that is called as en bloc turning. So these are all the features of Parkinsonian gait. A couple of other things, there is freezing. So if a Parkinsonism person comes across an obstacle, he will not be able to smoothly walk around it. He will have to stop, reorient himself, and then shuffle around. So there is freezing. he'll have trouble initiating the gait sometimes, and there is postural instability. So this is mainly because your basal ganglia is vitally important for all movement. And because there is dopamine deficiency, your basal ganglia is not working properly. So it is working very slow. So it cannot make quick decisions. So if you suddenly pull a Parkinsonism patient, even a little, a normal person will be able to recover their balance, but a Parkinsonism person will have postural instability. So that is an important aspect of Parkinsonism gait. Now, I keep saying Parkinsonism, but remember that it doesn't mean Parkinson's disease only. It has a lot of other diseases also, such as PSP, so progressive supranuclear palsy, and MSA. So you have all your Parkinson plus syndromes and plus all your drug-induced Parkinson. So Parkinsonism is a spectrum of diseases. It is not just one disease. And finally, we've reached your frontal lobe. So the important aspect of your frontal lobe is that your frontal lobe is involved in decision making, executive planning, and changing plans. So it is responsible for making a sequence of action, how to plan a sequence of action, and how to change those actions. So the problem in your cortical dysfunction, what all can go wrong is that you have trouble integrating those actions. So you have trouble integrating all the sensory stimuli that are coming to you. You have trouble putting them together. You have trouble initiating gait. So when you ask a patient with a frontal lobe disorder to start walking, you'll feel like his feet are stuck to the ground. So that is why it is also known as magnetic gait. So you'll feel like his feet are stuck to the ground, and even when he's walking, his feet are hardly lifting off the ground. So it is stuck. It is as if the feet are stuck to the ground. So it is called magnetic gait. He has trouble changing direction. So changing gait, that is an issue, and there are multiple names. So different people have described different things with frontal lobe gait, and the reason for that is because there is a huge spectrum of disorders that can affect the cortex. So your frontal lobe is not just one area. There is connections of your frontal lobe to every part of the brain. So to your cerebellum, to your every aspect of your cortex, to your brainstem. So if there is a problem in any one of these areas, it may look similar. So it is difficult to pinpoint exactly that the lesion is in one single part of the brain. So supposing you have a multi-infarct state. So supposing that there are small infarcts all over the brain, that can also present as a frontal lobe gait. Or if you have just one tumor in your frontal lobe, that can also present as frontal lobe gait. Suppose you have hydrocephalus. So your ventricles in your brain are filling up and they're pressing on the brain from all sides. That can also cause frontal lobe gait. So there is a spectrum. Some people have described specific differences, but in general, it is important to remember that you have gait difficulty in initiation, in changing direction. You have a magnetic gait. You have gait apraxia. So you have difficulty in planning how to walk. So your motor function is okay, your sensory function is okay, your cerebellum is okay, but you are unable to plan. So it is like somebody's given you a confusing thing to do. So walking becomes a confusing thing. Okay, so I think that's about it. That is all I wanted to discuss. I hope you understood the spectrum of problems that can happen in that can lead to gait disorder. And I hope you understood how to evaluate gait, and I hope you understood how gait is controlled, what is the neuroanatomy and physiology of gait, and what all variables will you look for when you examine gait. All right. Thank you all. I'll see you on Sunday. Bye.